Good morning, everybody. Welcome to this session, Part 10, Beyond PCI. My name is Sunil Rao. I'm an interventional cardiologist at NYU. I'll ask my co-moderator to introduce herself.
Hi, everybody. I'm Jacqueline Tamis-Holland from the Cleveland Clinic, and I guess we'll go down the panel to introduce everybody.
Good morning. I'm Nkechi Ijioma at The Ohio State University, Columbus, Ohio.
Anand Prasad from San Antonio.
Olga Toleva from Gainesville.
Srihari Naidu from New York.
Terrific. So we've got an hour-and-a-half session here, and we hope we get a lot of engagement from all of you. So it's my pleasure to introduce our first speaker today, the current president of SCAI, Srihari Naidu, who's going to talk about the future of cardiogenic shock.
Great. So I didn't bring any slides. I'm just going to talk to you guys kind of where things have been and where I think things are going, where Sky thinks are going, and I do want to open up the questions to see what people think. So, you know, some of us have been doing this for a long time, myself, Sunil, and Jackie, and back when I was a resident, the way we treated cardiogenic shock was fluids and pressors. And I remember very distinctly at Cornell when I was a resident that basically we gave fluids, pressors, we intubated patients early, and we saw how they went. And we saw a lot of patients who just didn't do well. We waited for the heart to recover. We did PCI. But a lot of them didn't recover. They got bloated. They got peripheral extremities, necrotic, and then we knew they were on the verge of dying at that point. And that's how we treated cardiogenic shock for a long time. We diagnosed it with low blood pressure, the need for pressors, and we didn't have things like lactate, and we used hemodynamics, but rudimentary in some ways. And it stuck with me that we didn't have a lot of solutions for these patients. Fast forward a few years, I went to the University of Pennsylvania, and we treated them fairly similarly. That was a transplant center now. And even at a transplant center, what we did was take these patients, and we might use balloon pumps at that time, but that's kind of all we had in terms of mechanical support. So these patients got transplanted. There was the beginnings of LVADs and BiVADs with big clunky devices, but not a whole lot of options. And the mortality rate was way over 50% for all these patients with shock. And we didn't have a lot to do. Fast forward a few years, early as an attending, and the Impella device came out. And I think there was a lot of hope at that time that there could be some role for more potent and versatile and streamlined devices that can improve the cardiac output. And it made a lot of sense that if you can just increase the cardiac output, you improve perfusion, and maybe you can get rid of some of the pressors, and maybe these patients will just dramatically get better. But then, and I did a lot of these, I was part of the high-risk PCI Protect 2 trial, and we were using a lot of them at Winthrop where I was, and patients still had problems. And so the field evolved to try to figure out, well, what's the real problem with shock? We did a bunch of trials, the IMPRESS trial, IBP, shock trials, and the devices weren't really working. Patients were still doing poorly. So a few of us got together in 2018-19 and came up with a new shock definition, which you guys all know and use today. It's the shock definition. And we divided it up into 5 different stages, as you know, and there wasn't anything really miraculous about it other than creating a language so we understood when patients were truly in shock, when they were getting worse, and how to go up and down that so that they get better. And what that did is it ushered in a new era of people really interested in cardiogenic shock, which is why people are here. They go to Sky Shock meeting. People are organized into teams, and a few things have happened with that. Number one, there's interest, which means we formed heart teams. A lot of the hospitals formed people interested in shock, putting their heads together to try to figure out why is this patient getting worse and how we can get them better. And we used some of these mechanical support devices. Some places used ECMO, some places used Impella, some places used balloon pump, or they used a combination of these things. But at the end of the day, what we learned from that is a few things. One was that if you can get the patient better, meaning if you can get them down to Sky Shock B or C, or certainly A, then they tended to do better. And we learned from the NCSI initiatives that Barbara and Bill O'Neill were doing that the patients after 24 hours who had a Sky Shock down to C or lower, they tended to have a much higher survival rate. So it made a lot of sense, obviously, if patients get better and they get better relatively quickly, that they're going to have a longer lasting result. And we found that in databases, if they had a lower Sky Shock stage within that first 24 hours, the lowest stage that they were in, the better their survival rate was, not just in the hospital or in the CCU, but also out to 1 year. So it does matter how bad they are in the hospital. That's the first lesson from the Sky Shock heart teams, that if you can keep them from being stage D or certainly stage E, these patients have a better short-term, intermediate, and long-term survival. So that led us to do a few things. One of the things in the Sky Shock pyramid that we came up with was how do you determine between the different stages? And one of the things that came up was something called lactate. And lactate has been used for a long time, but really wasn't used methodically in the way that we're using it now. And so I noticed at my hospital, we were drawing a lot more lactates. The fellows are here. They know we get lactates on admission, and we oftentimes get lactates in the cath lab. And we started putting things in place to draw lactates in other areas so that we can see where are we in the shock state, knowing that if it's over 2, we define that as sky shock stage C. So where are we right now? I think I learned that there's a few deficiencies in how we take care of shock. Number one is that 24 hours of getting the patients down to sky shock C or B includes about 12 hours where we're at home sleeping and there's a fellow, a resident, or a PA, or an NP hustling at night trying to get the patient better. So there's half the day that's in some ways wasted, that you're just trying to make sure the patient stays alive by the next morning. And that's an area that we oftentimes slip. So how can we make sure that those patients don't slip overnight? Well, that's where something called the dural lactate clearance comes in, which is really just saying we need to keep assessing patients frequently, day or night, weekends or weekdays, to see if we're on the right track. So what I think the future is going to be is really doing a marker that can be done anywhere. It's not a hemodynamics. It's not you have to put a PA catheter in all these patients or an impella in all these patients or whatever you do, something harder, but something easier, something biochemical that can be at the bedside and give you at least a week indication of whether you're on the right track. So one thing is the dural lactate clearance. We call it that, and it sounds more like a metric, but it really isn't. It's really telling people to keep assessing shock in the first 24 hours. What that does is that if you see that the lactate's not clearing within the first 6 hours, you may have to change gears, reevaluate, do another echo, do the hemodynamics, get more people involved, or decide to transfer the patient. But if they're getting better, you might decide not to escalate. And I think one of the problems with shock is that not only do we not escalate enough, but we sometimes escalate too much. So I've been surprised many times that the lactate's clearing. And we wouldn't go up on the presses. We wouldn't go up from a balloon pump to an impella. Because every time you go up, you also cause more complications that also cause survival problems. So one thing is that, and I thought the other way that this might help is that it might tie in different hospitals into a system. So I'm at a hospital, and every hospital that I've been to has been a place where patients, if they get sick, they end up going to the hospital in their network that might help them. They don't necessarily go to the hospital closest to them that might help them. And I think that that's a problem in my personal opinion, which is that if a patient is sick, they should be going to the hospital closest to them that allows them to take care of the shock state. And so one of the things that I think the dural lactate clearance might do is it might push systems to think beyond that, push government to think beyond that and say, if this patient is sick, they should go to the place that can handle it, not necessarily what's in their network, for example. And I think that's where the dural lactate clearance might help. So that's one thing. The other thing that's going to happen in the future of shock, I believe, is registries. So I know the American Heart Association has come up with a shock registry power with the guidelines. And all the time when we do major things, you need to track how it's working. Even lactate, we have to track if it's working. Are there unintended consequences we'll talk about? You know, oftentimes when there are things that you use, you can have ways that you can manipulate that. And what we want to avoid for sure is other people getting involved and saying that these are metrics, that these are things that we have to hit a certain number. Because that's not what we're trying to do. We're trying to hit the number of survival. So really it's about understanding how to get the patient better. So the registries will help. And I think sometimes people don't like registries because it means you have to put data into something, but it also means that you're being tracked. But I do think that the only way you can move the needle on some of these things is to make sure you're seeing what's happening, plugging the data back in, seeing what works, what doesn't work, and then let that feed into the system to get best practices going forward. So I think the shock registry by AHA is going to be helpful, and Sky is going to be, I'm on a call with them in a couple of weeks to see how Sky can work with the shock registry at AHA and try to incorporate some of these things. And the last thing I'll say is I think governments need to get involved in shock. Jackie and I sit on the Cardiac Advisory Council for New York, and I think some of the things that we talk about there are things like New York has Manhattan and the surrounding area, and it has a lot of rural America. And these places do not have a good way of taking care of shock. And oftentimes I'm sitting in my CCU and people are calling me from literally 3 or 4 hours away and they're begging to send the patient when every hospital says no. So I think that if we get patients treated quicker, understand their shock state quicker, get them to be transferred earlier in their care where they're not already 90% mortality rate, hospitals will take these patients, and also that there's a higher chance of survival. And I do think government should get involved in a way, putting together networks that prioritize shock as the next kind of frontier in interventional cardiology. So I'm going to stop there. with the future of shock. No slides. Easier for me. Thank you.
Thanks, Hari. And there are microphones here if people have questions or comments. So, Hari, I have a question. You know, one of the things we struggle with in New York, and I'm in New York as well, and I know you and Jackie are involved with the registry, is this whole definition of refractory shock, which, quite frankly, is complete nonsense. You know, in New York State, it's very, very difficult to get patients excluded because some MPH somewhere looking at the data will say, well, you had one blood pressure that was 90. And so you can't exclude this patient.
Yeah.
So how come you guys haven't been successful at getting New York State to change that? You know, I look at this list of people that are involved with this New York State registry, and they're the who's who of interventional cardiology. And I'm sitting there scratching my head and saying, what is the point of all this? Because you know, the New York State registry is public reporting. It's 3 years delayed. I'm having a difficult time understanding exactly what the value of this registry is in New York.
So I'm going to talk, and I'll have Jackie talk as well, which is that I was president of ACC for New York, and I specifically lobbied to get on the Cardiac Advisory Council to tackle this issue. And so it took about a year to get on it. Jackie was already on it. And I got on it, and they already had a shock subgroup. So I don't think it's really confidential, but there is a shock work group looking to reconcile the SCAI shock classification with the New York State shock classification. And there is a sense that it needs to happen. And so obviously whenever you do that, you then have to look at the data that you have, because it's just a two-page form, and figure out how do you use the current database that we have to put patients into these different categories. And then you have to check it against the prior databases to see if it's, as you know, to see if that it is consistent from year to year, that you're classifying patients appropriately. So that, I'm going to let Jackie talk about that, but I think that is something that we are doing, and I think you'll see it will be reconciled with the SCAI shock classification.
But how does the categorization help with? How does the categorization actually help with the quality reporting? Because the problem in New York State, so Massachusetts has figured this out, right? Massachusetts has taken every patient that's classified as shock or cardiac arrest, they independently adjudicate them, and then they basically exclude them from the denominator. So I understand that the sort of the academic reason to categorize them. I mean, you can write a bunch of papers about categorizing them, but the question ultimately is for sites.
Yeah.
You know, if you have a patient who has, you know, very, very severe, let's say SCAI class C or D shock, and they die in the hospital, and you've got one blood pressure that someone recorded as 90, that patient is not excluded from your metric, and it counts as a mortality.
Right. That's why the SCAI shock doesn't rely on blood pressure to the same extent. But let me have Jackie do it. I agree with you. I think the net should be cast wider. And the SCAI shock classification makes it a wider net, so all the shock gets eliminated. But
Yeah, I think that's exactly it. I think for those of you who are in New York State, you've probably seen the case report form has expanded for the shock variables. And I think what we're trying to do is to sort of see the way it's defined currently and the way we might say SCAI stage C or D, and see how refractory shock, how many patients in refractory shock, according to the New York State definition, correlates with SCAI stage C or D. But the only way we can do that is to get the data. And then I think that is the point. We definitely don't want people gaming the system, but we also do want to be sure that we are supporting the physicians. But if you recall, the emergency cases are being excluded from public reporting for physician level, right? So those are not reported.
that's a big
anywhere
change. So all of them get excluded from public reporting, but they're still reported internally.
So if it's an emergency case, but that's an MI within 24 hours.
Right. So I also think that New York State is looking at refractory shock, and we want to eliminate all of shock from this. Now, obviously, as shock mortality goes down for stage C, then maybe that will be revisited. But definitely, we are looking at that, and that's gonna happen over the next couple of years.
When you get these patients, how do you treat it? Just briefly. How special treatment you?
Oh, I think that's a complicated question. That really depends on a lot of things. So one of the things I didn't mention is we're also updating the new SCAI shock classification. And so when you look at that, you look at the stage of shock, the etiology of shock, the phenotype of shock. Different etiologies have different treatments. And so some of them need early acute management, interventional management, or surgical management, and then manipulation of the physiologic state. At our hospital, one of the reasons I like the door to lactate clearance or the lactate as a metric is that it allows people to do whatever they do at their institution to improve the patient. We tend to still use some balloon pumps and then move up to Impella 5.5 axillary in those patients and then decide if the RV is failing. Other places may go straight to ECMO. Other places may go straight to Impella. So I think it really depends on understanding what you have as a resource and expertise, matching that to your etiology and phenotype and timeline.
Evaluate them in future if you're going to mechanical support for a future destination therapy?
Yeah. I mean, if they need that, yes. But I'm also key to point out that oftentimes we over-escalate, and I think part of the mortality risk in shock is that we are overly aggressive in patients, and I do think that some of these things like lactate or hemodynamics will tell people when to hold the fort and wait, as opposed to aggressively going up out of fear. And I think lactate does help you do that. If it's going down, you know you can wait.
I have a question up here. So, you know, I practice in Texas, and just hearing the New Yorkers here talk. The public reporting, has it modified how you practice interventional cardiology and take care of these patients? And
I would say no, but I know that the data is that it does. And so I think if you look at a population basis, there's been population studies in New York and Michigan and other places where it's very clear that the types of cases that we do based on our population are not being reported. And so I think there's going to be people who do that. I think hospitals as a whole can oftentimes be less manipulated because they have so much of a denominator, and I think that there are, I mean, would I say that there are patients, I'll tell you as a director, if somebody has had a couple mortalities, I will do their next case, for example. I think we do things like that. So I don't think we oftentimes shunt them away, but I think we oftentimes will manipulate the system so that somebody else takes the hit. Now, Dr. Rao has been in charge of a cath lab for some time. I'm curious to hear what he thinks from the inner city about that.
Yeah, I mean, you know, I don't think there's any question that public reporting does, in fact, affect behavior. I mean, Fred Resnick has shown that very, very carefully. And, you know, this is my own personal opinion. I'm not speaking on behalf of any organization, but I think one of the worst things to have happened to cardiology is public reporting. It actually serves absolutely no purpose. The idea was that, patients will look at public reporting and figure out where to go. That's complete horseshit. I mean, you have to go where your insurance company tells you to go. And the reports are 3 years delayed. So it makes, and you know, we spend a tremendous amount of resources on this New York State database. And I'm just scratching my head thinking to myself, why are we spending so much money on this nonsense?
Because they also, even if they point out a hospital, they point out maybe one hospital that's 2 standard deviations or one individual. It's very rare that it's actually something that you know, makes a difference.
Absolutely, it's ridiculous. Well, thank you, Hari. It was a terrific talk. So we're going to keep moving, and it's my pleasure to introduce Mauricio Cohen, who needs no introduction. Mauricio is going to talk to us actually about the PCI guidelines for which he served as a co-author.
Thanks, Sunil. Thanks, Jackie. It's great to be here. Always thankful to this meeting and for inviting me throughout the years. So I have lots of slides to present, so I hope that I can go through them. These are my disclosures. So revascularization guidelines 2021, it was a great group. It happened at the end, a part happened during the pandemic, so we had to become creative and work through the pandemic to get this work done. The credit goes to Jackie and Jennifer Lawton, who were the chairs for these guidelines. So the guidelines have been now, it used to be a long document, and you would fall asleep just reading it. Now it's become as a modular knowledge chunk format with table of recommendations, brief synopsis, recommendations with supportive text, and these can be revised dynamically so things can be updated and put up to date so people can use them as a reference. So this is a big flow diagram that summarizes how to treat stable ischemic heart disease, which is at the crux of these guidelines. So here we have recommendations for left main. I don't think there's much controversy. So with left main, you go for the complexity of the CAD, yes or no. If it's complex, you treat with CABG. Recommendation is class 1. If it's not, you have PCI as an alternative. So let's move on to the next part, to the next branch of the algorithm, multivessel CAD, suitable for CABG or PCI. If it's ischemic cardiomyopathy, with an ejection fraction of less than 50%, you dichotomize with ejection fraction of less than 35 or more than, or 35 to 50%. So if it's a 35 to 50% CABG 2A recommendation, that's because of all these old trials. It's a 2A, not a 1, because those old trials just did not include an effective medical therapy. With less than 35, class 1 recommendation, we'll see a couple of slides, and then if it's not a candidate for CABG, then that goes to the heart team discussion. That was also a concept that was reinforced and introduced in the guidelines here. So for patients with left ventricular dysfunction, as I mentioned, with ejection fraction of less than 35%, the STITCHES trial, the extended follow-up of the STITCH trial shows that CABG has an advantage over medical therapy, and for patients with ejection fraction of 35 to 50%, the recommendation starts lays in 2A. But there was no word about PCI, so what happened after these guidelines? Then we have the revived BCIS-2 trial, even though we don't like this trial and the results of these trials, but this is the only trial that we have. It's randomized data. It's well conducted, published in the New England Journal of Medicine, shows somewhat better quality of life in the short term for PCI, but there's no advantage for PCI over medical therapy. So the guidelines will probably stay the way they're written, but now endorsed by newer data. So let's go back to that algorithm. Let's go to the patients that have more than 50% triple vessel disease. And here, this is the controversial area. So CABG that used to be a class 1 recommendation is now being downgraded to a class 2B recommendation and put at the same level of PCI. So, and this, I have to thank Jackie for many of the slides here. So in this, this is the text of the recommendation, and you can see that CABG may be reasonable for multi-vessel PCI, and the effect of PCI is uncertain, but the level of the evidence and the data are actually on par. So that created lots of discontent among some part of the components of the guidelines and the different professional societies. So we got this email in 2021 saying that actually AATS and DSTS, which are the surgical society, would not endorse the guidelines. So we have to kind of regroup and redo again. So this is a committee of the guidelines. So surgeons, so everybody knows, were not underrepresented in the committee. There were a number of surgeons there, Mario Gaudino, Joe Sabic, Steve Frames, among others. I'm just in the back serving coffee. So we lost the endorsement of this society. It was originally supposed to be endorsed by the STS and the AATS. And then there were a bunch of different articles that appear and articles written in different journals why would the surgeons not endorse the guidelines. And these were the major reasons. Downgrading of CABG in the treatment of three-vessel CAD, lack of recognition of the superior long-term benefits of CABG versus PCI, in decreasing repeat intervention and post-procedural myocardial infarction. That goes to global events, right? And then they were unhappy with the recommendation class 1 to radial artery as a CABG conduit. But the main objection was that it was downgraded from a class 1 to a class 2B in patients with three-vessel coronary artery disease. And then the 2023 chronic coronary disease guidelines maintained that same recommendation. And again, the surgeons responded to that with different papers in the literature. So where that comes from, and that comes from the early CABG trial. This is a use of meta-analysis published back in 1994, when many of the attendees were probably in elementary school. And some of them. And here it says that when you look at the different subgroup analysis, even though there's the P for interaction is negative, most of the effect you see in patients with three-vessel disease as a benefit for CABG. In the veterans, in the VA trials, 11-year survival, you can see that medical therapy was only nitrates, beta blockers, not even aspirin, not even statins. I mean, we had a wonderful lecture on prevention a few minutes ago that shows that none of those therapies that were mentioned are here. So no contemporary data. So more contemporary data, very 2D trial that was a more complex factorial randomization trial in patients with diabetes and coronary disease, where patients could be treated with PCI. There was a stratum with PCI and a stratum with CABG. And you can see that the effect of revascularization, even in these patients, don't have any effect with medical therapy, not for mortality, not for major adverse cardiovascular events. But now the numbers are large numbers. Instead of being just a few hundred patients, it's just thousands of patients. And you can see here that in the only group that was observed the benefit was for cardiovascular events, not for mortality, but for cardiovascular events when patients were treated with CABG. There's no significant differences in the patients treated with PCI. Then the ischemia trial, so that's also another trial that some people didn't like that much, but that trial showed no effect for an invasive strategy with followed with revascularization, and that had a follow-up at 4 years. No significant difference. There are some subtle differences in the interpretation of the data. I don't have time to go through that, but that's basically revascularization globally for patients with stable ischemic heart disease treated with contemporary therapy. About 75% of these patients, if I don't recall wrong, were treated with PCI. So, and then however you slice and dice the data, there was no subgroup that actually benefited. Here you have patients with 3-vessel disease or more, and here you have the patients with left anterior descending. There was no difference in the outcomes by baseline coronary CTA. And then in the patients with the highest risk anatomy, 3-vessel or 2-vessel with more than 70% proximal AD, Duke score 6. There's no difference between revascularization and medical treatment. Then a subsequent meta-analysis here by Sripal Bangalore, 14 randomized clinical trials, almost 15,000 patients, showed a very neutral effect for revascularization. But the surgeon's argument, again, is that only 16% had undergone CABG as their first revascularization procedure in the trials included in this meta-analysis. So then there's another meta-analysis in Navarez that looked at adverse events, not mortality specifically, but adverse events, and then there's an effect for adverse event like cardiac death and myocardial infarction. And you can see here that the effect is modest, but the effect is there. And you can see that there's a reduction in cardiac death, spontaneous MI, and then the guidelines committee decided, well, mortality is not showing any benefit. Cardiovascular events are significant outcomes that have to be considered. So there was a class 2A recommendations for patients with stable ischemic heart disease, multi-vessel CAD, that were appropriate for CABG or PCI. Revascularization was reasonable to lower adverse events. And then the surgeons came up with a new meta-analysis, and this meta-analysis involved 4 trials with 2,500 patients. And they looked at the outcomes, and they saw that there's an upfront risk for surgical procedures, but then the curves cross the curves cross, and then there's advantage to CABG when they're treated with contemporary medical therapy, such as aspirin, beta blockers, and statins, among others. So these are contemporary trials. But the problem is that they included the STITCHES trial that includes patients with ejection fraction of less than 35%. I don't know if these data are actually applicable or not to the discussion. So another aspect of the guidelines, another update of the guidelines, we've been talking about imaging. So finally, imaging to guide therapy has gotten a class 1A indication. This is very important and will hopefully help increase the use of imaging. And this is based on all the totality of the data. And then there are new trials beyond this meta-analysis that continue to show benefit. Here it shows benefit for mortality, cardiac death, target vessel MI, target vessel failure, and stent thrombosis. Significant effect. And finally, I cannot stop short of mentioning transradial access. Transradial access has been now elevated to a class 1 indication, thanks to all the work that's been done by Sunil and others. And so I would like to conclude here. So there's been a great advance in guidelines methodology with the concept of knowledge chunk that facilitates reading the guidelines and facilitates updating. An in-depth analysis of the benefits of revascularization or lack thereof in stable ischemic heart disease has caused lots of controversy and arguments and lack of endorsement and discontent from our surgical partners. IVUS for procedural guidance is now class 1, so that's a very good advance in the right direction. And then in the following lecture, Sunil is going to illuminate us more about acute coronary syndromes and will complement this lecture. Thank you so much.
Thanks, Mauricio, for a really great, detailed, opening up the dirty laundry, too. Discussion about the guidelines. Thanks so much. It was really great. I think that one of the big points is you talked about the revived PCIS trial, and at the time we put the guidelines out, we mentioned that we fell short of any recommendations for PCI and LV dysfunction. I'll open it to the panel. Nkechi, why don't you start by letting us know, how are you managing these patients now? We have these patients who are either surgical turndowns or perhaps even straightforward coronary disease with severe LV dysfunction, maybe even ischemia. What are we doing now for this sort of thing? Oh, you have it.
Just to make sure, so these are patients you're referring to have low ejection fraction, less than 35%, who are turned down by the surgeons. So I think, once again, the guidelines do recommend that heart team approach where the patients are part of that decision-making process. We meet with the patients, and then I tell them, it's going to be a high-risk procedure, but we can support you through this with mechanical circulatory support systems. And if the patient decides to go ahead, I do that.
Yeah, I think the challenge is that, in the face of the REVIVE trial, the question is, well, who are the patients who are going to benefit? I mean, this is the problem, is that I think we all have anecdotal evidence of patients whose EFs have gone from 25%, 30% to normal after revascularization done percutaneously. And so, it's very challenging. In clinical practice, it may be tough to figure out who those patients are. And there is a criticism of the REVIVE trial, which is a very, very good trial, and I don't mean to be critical of that study, is that at least one question that's asked is how many of these patients had non-ischemic cardiomyopathy with bystander coronary disease, and their primary myopathy never really improved. And then you start getting into the sort of existential question, right? So what is ischemic cardiomyopathy? And the traditional definition is a reduced ejection fraction with any coronary disease. And that's obviously a little bit unsatisfying. And I think it's a little bit of a gray area.
Yeah, and these were patients in the REVIVE trial were patients that were stable without refractory symptoms or any type of instability. So in those patients, I think that
why didn't they get CABG if there's a proven benefit, right? Why didn't they get CABG? So there's something going on. They're either surgical turndowns or didn't have enough disease. So it really makes you wonder about that cohort. Anand?
Yeah, so what I think it really does, the REVIVE trial, is it reinforces the importance of talking about CABG and seeing if, the patient can be surgically revascularized first. If they can't, then, you don't hang one trial to determine everything. You have to look case-by-case basis.
There are ongoing trials comparing PCI with CABG in patients with LV dysfunction. And I think that that's critical because you really wonder about the patients that are enrolled in the trials of PCI alone, how eligible they were for CABG. So the Stitches 3 trial will be looking at that. And I think it'll be really very helpful to see those results.
Yeah, and I think with REVIVE, the other problem was that they used MRI to evaluate the ejection fraction, but they didn't use an actual way to evaluate for ischemia, which would be the guiding method for us to understand if we alleviate ischemia, whether this ejection fraction will improve. So that, I think, was the key element. So in our practice, we do the same. We do a heart team approach. We usually offer supported PCI. And if we have good evidence for ischemia or symptoms that include ischemia, then we proceed with multivessel PCI.
All right, great. Are there any questions from the audience? So Mauricio, with the data, I know a lot has changed with the ACS guidelines. We have a minute or two, right?
Yeah,
we're missing a speaker in here. So a lot has changed and been updated in the ACS guidelines. But what would you say, perhaps, besides the PCI and LV dysfunction that might change or might not change with future iterations of a REVASC guidelines, what would you say in the stable ischemic heart disease realm? Has anything changed that you can see an update in future guidelines?
I don't see much changing in that particular group of patients with CAD and more than 50% ejection fraction. I think medical therapies, we had a long lecture on medical therapies, improve prognosis, to stabilize the plaques. I think that everything is going to come through medical therapy. And in the patients who are still having symptoms and have, and then the other issue is patient preference, because we put the patient at the center of and patients want to be done. I mean, if you show a patient a 95% lesion in the proximal LAD, even if they are asymptomatic, they want to be done. The referring doctor wants a patient done. So I don't know sometimes how to deal with that. I even suggested Manos a lecture. So, patients come with a calcium score of 2,000, and they are referred to the interventionalist. So what do you do? And what do you tell patients? So I think that most of the progress is going to come with medical therapies and better understanding of stable chronic coronary disease.
The problem with those cases is, straightforward anatomy, it's 90%, you put a stent in and they have stent thrombosis, dissection, bleed.
Yeah.
Everybody's like, hey, this patient had no symptoms, no ischemia, why did you do that? If you don't do it, and they have a heart attack, maybe randomly a month later, then why didn't you do it? So I feel like we get kind of screwed both ways.
But the argument for the heart attack, that it's
I know.
unlikely to happen. I mean, this population is a population that have a low risk of events over time.
It just takes one or two cases to make your life miserable, right?
And I think that's why it's very nice that the guidelines have moved to that, putting the heart team and having the patient at the center of our discussion in the guidelines now, that we should involve patients when we make those decisions, and of course go case-by-case basis as well. But then document is also important. Document your discussion, document that you discuss the risk and benefits.
Yeah, it's a great point, and it brings me sort of to another question, which is, what's the heart team? Because if you ask people, I bet you if I asked everybody in this audience if you have a heart team approach in your hospital, everybody says yes. And then the question is, well, what's the heart team? And I suspect that some people will say, well, it's me and the cardiac surgeon that I call. And then other places actually have a very, very formal heart team where they meet every week. And I think part of the challenge, and Jackie may remember that I actually was one of the dissenting voices around giving the heart team a class 1 recommendation, the revascularization guidelines, is because we don't have any data behind it. It was actually developed in the context of the syntax trial and the partner trial to make sure that patients were eligible for both for randomization. And for some reason, it's just become translated as like motherhood and apple pie, where everyone's got to do it. But it's actually very difficult to implement in clinical practice, because particularly in a place like New York City, taking a patient off the table to have a discussion is just, given the pace of what the cardiology practice is in New York, and I suspect in any other place, I mean, it's not unique to New York City, it's very, very difficult to do that. And so, the ideal heart team is kind of the surgeon, the interventionalist, the non-invasive cardiologist, the patient. But I'll tell you, I've been in New York City for 3 years. The most aggressive interventional cardiologists in New York City are the non-invasive referring docs. They want you to put a stent somewhere before you send them back.
Mauricio, a quick point on the word of asymptomatic, because that's something we are dealing with every single day. So if somebody is sitting just watching TV doing nothing is asymptomatic, that's one category. And if you do a treadmill stress test, they do fine for 12 minutes and they're asymptomatic, that's totally two different patient populations. So I think it's on us as probably interventionist coronary specialists to define who is really a stable ischemic heart disease and is asymptomatic. So for me, like doing the stress test treadmill just without any nuclear or anything gives me a ton of information. That's totally different patient.
Yeah.
Yeah,
That's a good point for sure.
I oftentimes try to sort of squeeze anything out of them when it's like a 95% lesion. If you talk more and say, I don't get short of breath, well, what do you do? One, why are you not walking a mile a day? And then you're like, oh, because I get short of breath if I try. Stefan?
Yeah, just want to say, for someone like me who's often at the end of who takes the crumbs coming from surgeons, the reality is that the real heart team nowadays is that if the patient's not a lunch for the surgeon, then you get what is for you. Never surgeon will say, this guy, I'm looking at the whole anatomy, and I think it'd be better served with PCI because it's too low risk for the OR. Never happens. The surgeon will look, and when it's too high risk, then it becomes to you. But they will never go back and circle back to say, I got this guy referred, he's got a mid-shaft left main, why don't you just put a stent in there? They will never do this. So it's sort of this is a process of heart team that I've seen for the last 25 years, and it's never changed. So one thing. Second, when you're going, just to talk about Revive BC's beautiful trial, however, the current status of how the patients are actually referred to use a very different pathway right now. They're coming, they usually have their first episode, they're in heart failure, they had non-STEMI, they had something, and then you get involved in that context of 3-vessel or, a surgery, and really the ones that are sitting out there with a low EF and 2-vessel disease, it's not really our practice. I'm just not seeing this. I don't know if anybody sees this like, hey, by the way, this one's asymptomatic, he's got 2-vessel disease. Let's just see if we're going to put stents in.
So you mean that the trial is not representative of clinical practice?
In some way, yeah.
Yeah, great points. I think I want to move on because Dr. Sunil Rao is going to talk to us about ACS guidelines. And even though we do have some time, because one of our speakers had to leave early, I want to make sure we have time to discuss the ACS guidelines. So Sunil needs no other introduction. He did a fantastic job, so go ahead.
Yeah, great. Thanks so much, and thanks to Manos and the team for inviting me. I sort of noticed this format before I got here. I just came in last night. I noticed this format, and I have to admit it made me a little bit nervous because this is very different. And I was talking to my wife about it, and I said, I'm kind of nervous about this particular format because it's a more TED Talk. And she said, well, just don't try to be intellectual, witty, or charming. Just be yourself. So I'm going to try my best to keep you guys awake during this ACS guidelines talk. I don't have any disclosures related to this lecture. Any opinions that I'm expressing or have already expressed do not reflect the official positions of any of these organizations. One of the biggest challenges with guidelines talks is that it is very difficult to make them interesting. I mean, Mauricio did a great job because oftentimes these guidelines talks are nothing but just tables of the recommendations, and people are just reading them. And you can read the document. The question is, how do you actually translate that into something that's interesting and applicable at the bedside? So what I hope to do is to give you a little bit of a peek under the hood of what the guidelines process is like, because I think there's still a perception that the guidelines process takes place in some back room with people who really don't have a lot of expertise, and then a lot of it is just expert consensus. It's actually not true. There's a very, very intense and vetted process for how these recommendations are developed. There's a multidisciplinary and transdisciplinary writing committee that has multiple organizations that are represented on it. Some guidelines are even available for public comment. There's a very, very intense peer review process as well. Our ACS guideline underwent 2 sets of peer reviews with over 250 comments. So other people are looking at these recommendations as well. It's not something that we just come up with. And then I'll take you through some selected recommendations. Rather than kind of reading the document, which again will put you all to sleep, particularly before lunch, I'll just go through, I think, some of the selected recommendations. The last time the ACS guidelines were published was in 2013, 2014. So it's been 10 to 11 years, and you can imagine the volume of data in ACS that have come out since then that we had to consider, and then we'll wrap up. So what's the background of the guidelines process? Well, the first set of treatment guidelines for unstable angina were released in 1994. It was a public-private partnership between what was called the Agency for Healthcare Research and Policy, that is now called AHRQ, Duke, and the Brigham and Women's Hospital. Bob Jones, Eugene Braunwald, and Dan Mark were the first authors of that particular document. That document put into place certain processes that are still in place now for every guidelines document. A literature review, evidence tables, intense discussion about actually what the recommendations are going to be, levels of recommendations, and then the peer review process. All of that was not existent before 1994. If there were any guidelines or consensus documents, it really was a bunch of people sitting around in a room saying, this is how I treat at my hospital, and they seem to do pretty well, so this is what everyone else should do. So now it's a much more quantitative process. This is how the overall guidelines committee works. It's a joint partnership between the American Heart Association and the American College of Cardiology. There is the Joint Committee on Clinical Practice Guidelines. Catherine Otto is currently the chair. I'm the chair-elect of that committee. And then there is a writing committee that is selected for every single guideline. The writing committee has to have 51% of people who do not have relevant conflicts of interest related to that topic. So it doesn't mean that the entire committee can't have conflicts. It just means that 51% cannot have conflicts. And you can't vote on specific recommendations if you have a conflict of interest. And these are financial conflicts of interest. I think we all recognize that there probably are intellectual conflicts of interest that go into these documents, and that's something that we have to wrestle with. The writing committee has a chair and either a vice chair or a co-chair. We actually had 2 vice chairs on the ACS guidelines. And then there's a writing committee that comprises different individuals of different specialties that may have some skin in the game for that particular document. Separately, there's a peer review committee that is also selected, and there's a chair for the peer review committee. That committee will review this document before it gets published, either once or sometimes twice. And then, of course, there are plenty of staff members from both of these organizations that help to support the process. You can imagine that this process is evolving very, very rapidly. When we worked on the revascularization guidelines, people who were assigned to each section had to do their own literature searches with the help of a librarian, as well as create these evidence tables. Now that we've got AI, and large language models, that process is becoming much more streamlined, recognizing, of course, that we have to make sure that the references are not being hallucinated, and that's going to continue to be a challenge. For the acute coronary syndrome guideline, we invited the American Association of Thoracic Surgeons, the American College of Emergency Physicians, the National Association of EMS Professionals, SCI, and STS to be partner organizations and have writing committee representatives on the document. All of the organizations responded except for the AATS and the STS. They never responded to the invitation. So I know that after the ACS guidelines were published on social media, there was some criticism of the fact that there were no surgeons on the writing committee. That's actually false. We had 2 surgeons on the writing committee. Mark Rule is a cardiac surgeon who is the vice chair, and Sigrid Sander from Europe is also a cardiac surgeon who is on the writing committee. But there was no official representation from these organizations simply because they chose not to respond to the invite. So these other organizations had official representatives on the writing committee. We also had reviewers from ACEP and SCI, and then this document was endorsed by ACEP, the EMS Society, as well as SCI. This is the document. I encourage you to take a look at it and read it if you'd like. Feel free to use it for kindling if you want, if you don't like some of the recommendations. But we had to make some decisions. So we were given 14 months to put this document together. I'm proud to say that we actually came in on time. Mauricio was part of the writing committee for these ACS guidelines. Jackie was our liaison, and I think no one knows the data better than Jackie Tamis-Holland. I mean, if you want to know what a trial said, ask Jackie. She knows. She knows it like the back of her hand. So she was invaluable to this entire process. She also has the wisdom of Solomon because she's been involved with the guidelines process for so long. So if we had any controversial areas, Jackie was instrumental in sort of resolving those things. So I really do want to thank her for her help with this document. But we had to make some decisions in order to make this process go smoothly and in on time. So one thing we had to do was decide on what is an acute coronary syndrome? What is a myocardial infarction? It's not so easy anymore. When I was in training, MIs were pretty easy. You had an elevated CKMB and the patient had chest pain, and then we had non-Q-wave or Q-wave MI. Now we've got all kinds of classifications. But because the randomized trial evidence that we considered for this document presumably included only patients with type 1 myocardial infarction, we decided to limit the document to type 1. Now, we fully recognize that in the 18,000 patients in the Plato trial, there probably were some type 2s. But the assumption underlying the treatment randomization was that these patients had plaque rupture, which is why we limited the document to type 1 MI. We also got some criticism for not using the occlusive MI or obstructive MI and non-obstructive MI, the so-called OMI and OMI classification in EKGs, which I do think is probably going to be the future. But again, the reason we didn't include that classification was because those classifications were not included in the randomized trials. So now I think you're getting a little bit of a flavor of what the ground rules are. Okay? The ground rules are we have to be adherent to what the randomized trials say. The other ground rule is that if there was a previous guideline statement that gave a recommendation to some treatment strategy, and there were no new data to refute that, we could not necessarily change that recommendation without really sort of a large discussion about why we're changing it. So for example, if a randomized trial said that in 6-foot-tall redheads, treatment A was better than treatment B, the language of the recommendation is in 6-foot-tall redheads, treatment A is preferred. So again, we have to be very, very adherent to what the randomized trials say. And you can think about what the complexity of some of these randomized trials, right? They don't all use the same endpoints. Some of them mix safety and efficacy. Some of them had patients with acute coronary syndrome mixed in with patients with stable angina. So these are the kinds of things that we had to deal with. So let's talk about what some of these selected recommendations are. As I mentioned, there's a tremendous body of evidence that was developed in the 10 years between the last document and what we dealt with in the current ACS guidelines. But what's foundational therapy? Well, this hasn't changed much, and I'm not going to spend a lot of time on this. I think that you all know these data. Certainly, the newer P2Y12 inhibitors are recommended over clopidogrel when they're available and a patient doesn't have a contraindication. Just to remind you of what the trials showed, both CURE and PLATO were trials of patients who were randomized prior to the cath lab visit. So they included patients who were treated with just medical therapy, who underwent PCI or with bypass surgery. Triton, which is the prasugrel trial, was largely a cath lab-based trial. Some patients underwent CABG, but really it was a PCI-related trial, which is why the guidelines are worded in such a way that if a patient is managed without planned invasive evaluation, ticagrelor is recommended. If it's a patient undergoing PCI, either prasugrel or ticagrelor is recommended. We got a little bit of criticism for why we didn't give prasugrel a higher recommendation than ticagrelor based on the ISAR React 5 trial. That's a randomized trial that was done comparing those two agents. Again, it's one trial. It was unblinded. It didn't show an increased risk of bleeding with one over the other, so it was a little bit, not necessarily definitive as we'd liked. So we decided that the body of data really supported one or the other, not necessarily one over the other, like the ESC guidelines. And if people have questions or comments about that, I'd love to hear about what people's thoughts are. Then there's the whole issue of upstream therapy. Okay, so what do we mean by upstream? I think when we're talking about ACS, upstream, the parlance really means prior to the cath lab visit. When you look at the registry data, it's still about 50% of hospitals will load patients with a P2Y12 inhibitor before they go to the cath lab, 50% don't. I used to work at Duke, we didn't load anybody. I work at NYU now, we load everybody. So a lot of it comes down to practice patterns. There really has not been a randomized trial showing that upstream therapy is beneficial, particularly in an era where most patients are going to the cath lab within 24 hours. In the old days, in the CURE trial, the median time to cath was several days. There probably is a benefit in that particular population. So we really couldn't give upstream therapy a strong recommendation, and it ends up getting a class 2B in the current guidelines. Now let's talk about parenteral anticoagulation. Again, you can separate that into the patients who are in the emergency department versus those who get into the cath lab. What I've shown for you on this slide is all the agents that are in green, which you get a class 1 recommendation for upstream therapy. I don't think anyone's really using fondaparinux except for Chris Granger at Duke, but it does get a class 1 because the trial was positive. Heparin and enoxaparin really are the upstream agents that get a class 1 recommendation in NSTEMI. And then for PCI, we have 2 agents that get a class 1 recommendation, heparin and bivalirudin. Bivalirudin really gets a class 1 recommendation in STEMI, largely based on the BRIGHT 4 trial. This is a trial that compared bivalirudin with unfractionated heparin in primary PCI, 95% radial approach in that trial, with a prolonged bivalirudin infusion. And in that trial, interestingly, the use of bivalirudin with an infusion reduced the risk of MACE as well as stent thrombosis, which gets it a class 1. But heparin also gets a class 1, and enoxaparin gets a class 2 recommendation. Fondaparinux, as many of you know, is not recommended by itself in the cath lab. There's an increased risk of catheter thrombosis unless you use additional heparin or bivalirudin. Interestingly, one of the things that we wanted to talk about in the ACS guidelines, well, what do we do with patients who are anemic and come in with an MI? The previous iteration, I think it was in 2010 or 12 ESC guidelines, mentioned that transfusion can be used in patients who are anemic with an MI and transfuse them to a hemoglobin of 8. Now, the problem with that particular recommendation at that time was that it was based entirely on observational data, some of which was, I participated in. But the randomized MINT trial, which is funded by the NHLBI, that reported out last year, really is the largest trial that compared transfusion strategies in patients with acute MI. It was 3,500 patients. And it showed that there was a slight advantage of a more liberal transfusion strategy. So quite frankly, all the observational data were wrong. And so because of that trial, in patients with acute coronary syndrome and acute or chronic anemia, blood transfusion to achieve a hemoglobin level of 10 gets a class 2B recommendation. It's a little bit of a milder recommendation because the primary endpoint didn't quite reach statistical significance, but cardiac death, in fact, was lower in the patients who achieved a higher hemoglobin with more aggressive transfusion. Now, there's been a tremendous number of trials looking at non-infarct-related revascularization, or non-infarct artery-related revascularization in patients who come in with STEMI. Some pilot trials were done, and then all of you are familiar with the complete trial, which really is a definitive trial that showed that doing PCI of a non-infarct artery reduced not only MACE, but there was a reduction in mortality with that particular strategy. These are all patients who are not candidates for bypass surgery. So that's quite a change from the 2013-14 guidelines, and it's a new recommendation in our current ACS guidelines. In patients with ST segment elevation MI who are hemodynamically stable, if they have low complexity multivessel disease, it's a class 1 recommendation to undergo PCI of the non-infarct artery. You can do it either at the time of the primary PCI or as a staged procedure. As you all know, there's one trial that actually compared doing it at the same time or as staged. That trial was positive, but it was driven by periprocedural MI. You know, for those of you who participate in clinical trials, you know that it can be very difficult to tease out periprocedural MI from the index MI, which is why we decided to give it a 2B recommendation to do it at the time of primary PCI. Personally, as an interventionalist, I'm glad it gets a class 2B. The last thing anybody really wants to do at 3 a.m. after fixing an infarct lesion is to do some kind of crazy DK crush of an LED diagonal, right? So I think many people are actually staging these procedures, which I think is appropriate. Of course, all of these trials had the one caveat that the patients were not candidates for bypass surgery. And so if patients have very, very complex disease, then of course bypass surgery should be considered. Now that's very different than if a patient has cardiogenic shock, because the randomized trial of multivessel PCI and cardiogenic shock not only showed no benefit, but actually showed harm with multivessel PCI. Now, we can debate, and we probably should debate, why that is. I mean, these patients, remember in the culprit shock trial, it was kind of an all-comer shock study. Many of these patients had very severe stages of cardiogenic shock. Many of them had out-of-hospital cardiac arrest. You know, it may be that at that point there was nothing you could do, including PCI, that would actually salvage these patients. But in fact, it showed a higher risk of death or renal failure in patients who are randomized to get multivessel PCI in the setting of shock. That doesn't mean you shouldn't really ever do it. If you talk to the PI of this trial, he will tell you that once the shock is stabilized, then it's entirely reasonable to go ahead and address those lesions, but it certainly should not be done at the time of primary PCI. Again, that's a new recommendation, a class 3 for that in shock because of the harm. In STEMI, it's very similar. Patients who are hemodynamically stable, the mode of revascularization really depends on the complexity of the anatomy. Very, very high syntax score should go to bypass surgery. Less complex disease can get PCI. There is a randomized trial that's going on now called Complete 2, which is randomizing patients with NSTEMI and multivessel disease to angiography-guided versus physiology-guided PCI. So stay tuned for that. That will probably report out in the next few years. All right, let's talk about mechanical circulatory support, because this is the first time that a mechanical circulatory support device strategy has gotten anything but a class 3 recommendation in the guidelines. And this is because of the danger shock trial. All of you are familiar with that. It started out as the Dan shock trial. They got really lucky because they added Germany, and they could actually change their acronym to something really cool like danger shock. And these patients were randomized to get routine care versus the use of the microaxial flow pump, also commercially known as Impella CP. This trial took 10 years to enroll, but as all of you know, there was actually a reduction in 180-day mortality with the Impella strategy. Multiple reasons for that. I think they selected out patients who were likely to survive. So unlike the shock trial, the shock trials that were done with balloon pump like IABP Shock 2, out-of-hospital cardiac arrest patients were allowed in danger shock only if they had a good Glasgow coma scale. So again, the patients who were really unlikely to survive were not randomized. And I think patient selection is very, very important. The other thing that they did was they looked at a 180-day endpoint. For those of you who remember the shock trial, which led to a class 1 recommendation for PCI in shock, the 30-day endpoint was negative. It was really the 180-day endpoint that was positive. And that's probably because in these shock patients, there's so much going on in that first 30 days that can affect mortality. In fact, if you look at the survival curves in danger shock, there's a spike early on within the first 48 hours, and then there was a spike later on as patients died of other things. And the reason that it doesn't get a class 1 recommendation in the current guidelines is because there is a risk of complications. The bleeding rates were higher, vascular complication rates were higher as well. So it's a class 2A recommendation for the use of the microaxial intravascular flow pump in selected patients with STEMI and severe or refractory shock. All the other mechanical circulatory support devices get a class 3, no benefit. Now, we fully recognize on the writing committee that we've all had patients who improve with a balloon pump, who improve with ECMO. The key word here is routine use. So if a patient comes in with SCI stage C shock, it should not be routine to put that patient on ECMO. It should not be routine to put that patient, to give that patient a balloon pump. So routine is really the key word in that no benefit document. Again, we have to adhere to how the trials were designed and what those outcomes were, recognizing, of course, that clinical judgment should, of course, nuance some of the decision-making in these patients. Mauricio already talked to you about intravascular imaging. It's really quite amazing. You know, the revascularization guidelines came out in 2021. That's not that long ago. And in that period of time, there were 3 randomized trials that showed that intravascular imaging reduces mortality in patients who are undergoing complex PCI. Again, one of the criticisms we got was, why didn't you just say that every patient should get intravascular imaging and not just the complex patients? Again, the trials that we were considered for this recommendation were complex PCI patients, left mains, bifurcations, et cetera. Now, certainly I recognize that in order to have it integrated into your workflow, you probably should be doing imaging on all of your PCIs, even the type A lesions. Radial approach, I think Mauricio already talked to you about. This was carried over from the revascularization guidelines, primarily because the benefit of radial access on hard clinical outcomes was really shown in the ACS population, particularly ST elevation MI. Now let's talk a little bit about DAP strategies at discharge, because this is one area that's been incredibly ripe with evidence, right? There's been a lot of trials that have come out, multiple different recommendations, multiple different endpoints, a lot of which were including bleeding as well as efficacy. So we had a lot of work to do, and Ismail Babar did an incredible job writing this section. He led the Twilight trial. So the default strategy is still 12 months of DAPT, and this is consistent with the ESC guidelines. I think when our conversations around, how long should I treat, really the question that we're asking is, when is it safe to stop? Because if there was no risk, I think we'd probably treat patients indefinitely. So in most patients, 12 months of DAPT is still foundational therapy. But there are strategies that you can use to reduce the bleeding risk. In an all-comer population, like in the Twilight trial, you can drop the aspirin after 1 to 3 months of dual antiplatelet therapy and continue ticagrelor at the 90 milligrams BID dose. That's the Twilight strategy. That gets a class 1 recommendation. Certainly if a patient's on oral anticoagulation, we know that dropping the aspirin reduces the risk of bleeding without compromising efficacy. The big question is, how long should you treat with triple therapy? The ESC guidelines are prescriptive on this. They actually give you a certain time frame that you should use triple therapy. We elected not to do that. There are some data from the apixaban trials. My former colleague, John Alexander, did a very nice job looking at the duration of therapy with triple therapy to reduce the stent thrombosis risk. It looks like somewhere between 2 to 3 weeks is probably the right answer, but we don't really know. But again, dropping aspirin long-term and using a P2Y12 inhibitor plus a DOAC gets a class 1 recommendation. And then there are patients who are so-called high bleeding risk. These are patients who are anemic, who are frail, who have a prior history of bleeding, or who may have a surgery coming up. And in those patients, you can see that those columns are orange, because some of these trials that have looked at so-called de-escalation have not shown a reduction, have shown an increase in MACE in the ACS population. So the ACS population is a little bit different from the stable angina population, but if you have to de-escalate, there are some strategies you can use. You can de-escalate the potency of the P2Y12, in other words, go from ticagrelor to clopidogrel. You can drop the aspirin and simply use single antiplatelet therapy with a P2Y12 inhibitor or aspirin. And then there's a genetics-guided strategy, like the popular genetics trial, where you can look at genotype and use that. One of the things that we were charged with on the writing committee is determining when a patient with ACS becomes a patient with CCS. When does that acute coronary syndrome patient become a stable angina or a stable ASCVD patient? If you've read the guidelines, you'll notice that we actually didn't comment on that. So we decided actually not to comment on it, because I think the writing committee felt that it's probably different for every patient. Some patient may become a stable ASCVD patient much sooner than others, and we're just simply not smart enough to figure out who that patient is. And that's why foundational therapy is still 12 months of DAPT. So how have we done? I think my
One of my mentors, Rob Califf, is fond of saying that the guidelines aren't really based on evidence, and that's a charge to the community to develop more evidence. Alex Vanderoff wrote this paper, looking at the 2014 NSTEMI guideline, showing that only 15% of the recommendations in the guideline were level of evidence A. Well, we've gotten better than that. Now it's about 27%. And still 50% are level of evidence B, but only 20% are level of evidence C. So that's really because of the amount of evidence that all of us are really generating as a profession in terms of randomized trials. But the other thing that I think is important is that 66% of the recommendations in the document are based on randomized trials. Remember, level of evidence A means that you have more than one trial. A lot of the recommendations are level of evidence B, but randomized. So at least there's one randomized trial. So 2/3 of the recommendations in the ACS guidelines are based on randomized trial, which is much better than in the past, and I suspect this number will continue to increase over time. So in summary, the ACS guidelines really provide the best summary of the evidence base to improve outcomes. It's the first update in 12 years, which includes contemporary randomized trials. And for the first time, we combined NSTEMI and STEMI into the same document, because overall, the treatment strategies are similar, although they're not identical. The foundational strategies are still the same: antiplatelet therapy, antithrombin therapy, and invasive risk stratification. But we've got a lot of new recommendations in there, including how to deal with multivessel disease, how to deal with anemia and blood transfusion, intracoronary imaging and shock. But of course, the next challenge for us is how do we implement these? Because we've been talking about the implementation gap for a long time, but now that we've got the power of electronic health records and AI, hopefully we'll have fewer and fewer patients not being treated according to the guidelines and what they say. I do have to thank the vice chairs of the ACS guidelines document, Michelle O'Donoghue, who has an encyclopedic knowledge of clinical trial data, and Mark Rule on the cardiac surgery side, as well as the writing committee. Again, Mauricio and Jackie were both part of that, the ACC AHA staff, and of course our peer reviewers. So thank you very much for your attention.
Sunil, that was a really fantastic tour de force. Really great, and congratulations on your guideline. I think that everybody within the community knows that you're the poster child for how you should be a chair and how you should handle things, and everybody's going to try to model after you. So great work. I think you've posed some incredibly important points. Sit down. Yeah. Let me first start by saying, is there any questions from the audience? Because there's a lot of comments.
So there's a mic in the front. Also, they can take the mic to you if you don't want to come to the front.
Well, a quick comment, obviously, a masterful summary of all these guidelines. It's an amazing write-up, and congratulations to everyone involved. From a lot of other issues, and I really want to focus on the balloon pump indication. I struggle with that. My physicians, my referring physicians struggle with that, because this is a very commonly successful, fairly successful practice. And for us to define something as a class 3 has some potential dangers associated with that. Do no harm, and class 2B, I'm just thinking this through as to we don't have any recent trials comparing balloon pump to anything else except for the PROTECT trials. And these are last 10 years, last decade of experience. So how did you guys reach to this conclusion that it deserves a class 3 and potentially can endanger most of the physicians who are doing this routinely? You got a left main lesion, put in a balloon pump. Somebody's blood pressure is low, you put in a balloon pump. Transfer this patient to tertiary care center. I wonder if you can give us some elaborate on that.
Thanks, Alpesh, for that question, because I think it's really important, because the guidelines tie into so-called performance measures, and this is where the process is not perfect. So the decision to give it a class 3 was actually relatively straightforward, because again, that's what the randomized trials say, right? So the randomized trial gets the highest level of evidence. Now, your comment about the sort of high-risk PCI is a little bit, it's related, but a little bit tangential, because again, this is not, the recommendation is specifically for shock. I do think that it's important to translate the guidelines in the context of clinical care. And I totally agree with you. I mean, we have patients who do improve with a balloon pump. And that's why I think that the important language in the guidelines is really around the routine use of a balloon pump for shock. As I mentioned, if you've got a patient with SCAI C shock and your routine strategy is to use a balloon pump without transferring that patient for sort of higher level of care, I mean, I'm not entirely convinced that that's consistent with the data. So that's where our hands were a little bit tied. If the randomized trial shows no benefit, then it is difficult for the guideline statement to do something that's counter to that because of the way the ground rules are set up.
Yeah, and I agree with you exactly, the struggle you guys must have gone through. But I'm just curious, I mean, I'm not even sure that we are necessarily convinced that it does harm.
Oh, so it's a no benefit. It's a
Well,
no
it's
benefit.
class
Yes.
3 now.
So class 3 can either be harm or no benefit. So that's why it's actually separated in the guidelines. For multivessel PCI, because there actually was harm, it's a class 3 harm. For balloon pump, it's a class 3 no benefit. Yeah.
I believe it was also in the prior 2013 STEMI guidelines. So it's not like it's changed. It was a class 3 then, if I'm not mistaken. So we haven't changed it since the IABP shock trial.
Great work and lots of data. My question to you, Sunil, is we know the impact of complete revascularization following STEMI. What is the status? There are recent trials on the complete revascularization in non-STEMIs and ACS, and the role of any guidance, let's say functional, IFR, FFR. So where did you sit on this, and is it worded anywhere into the document? I just disclosed that I didn't read it. So what?
No,
I know.
No, so it does get a class 1 for complete revascularization with the caveat. I think part of our discussion,
Even in non-STEMI? Yes.
Including non-STEMI, yeah.
Okay.
And part of the discussion that we had was, one of the challenges is that how do we define complete revascularization? That's actually been a little bit of a challenge, right? Because each study is done, it's defined a little bit differently. The other problem, of course, in NSTEMI is that 25% of the time we get the infarct artery wrong when we're doing PCI. So it does get a class 1 for complete revascularization, however it's defined in the studies. The issue around physiology is a really, really interesting one because there is a negative trial, right? And so that's why it didn't get a class 1 recommendation for physiology-guided revascularization in NSTEMI. Having said that, I suspect that the complete 2 trial will actually address that particular question, and the ACS guidelines will probably have to be updated based on that particular trial.
I think for physiology, in STEMI, there's no evidence. And complete 2 will help. With non-STEMI, there's a little bit of evidence, and that's why there was a recommendation. So in STEMI, we actually don't have a recommendation. In non-STEMI, we have it as a 2B.
Sunil, great presentation, and congrats on the body of work that obviously underpinned this. I want to come back to the balloon pump issue, and I think when you say that the data are pretty clear, yes, the data are pretty clear that a balloon pump in shock doesn't work when deployed after PCI. And to me, that's the key, because Thiela's study actually had the balloon pump deployed after the PCI in 82 or 84% of cases. And their explanation was, well, the patients who had it deployed it just as well, so it probably didn't matter. But I think it does matter, and I think we have mounting data that earlier deployment of MCS is beneficial. And we have, though you don't have randomized trial data, you have observational studies that suggest, like with Impella, observational studies that in shock, if you deploy a balloon pump early, that they may be associated with better outcome. There are small studies, but I'm afraid that a level or class 3 indication will stifle any ongoing research in that. So that's kind of the only thing. With respect to danger, it's the first trial of an MCS device that actually forbade the use of a balloon pump as in the control group. And I understand why in Europe, because they have that class 3 indication or contraindication. But to me, that's an issue with this trial, because all prior small studies of tandem heart versus balloon pump, Impella versus balloon pump, showed equipoise, showed no difference in outcome in hard endpoints, or in mortality, I should say, between those two groups. So this is the first trial that actually excluded the use of the balloon pump in the control group. That I have a problem with.
Yeah, I think you bring up some good points. I think that your point about the observational data and earlier use, I mean, you're right, it is observational data, and we always have to be really careful with that when we use that to inform guidelines. But your point is a good one. I mean, again, we're sort of held to what the trials showed. I think it would have been very difficult for them to, and I'm not speaking on behalf of the danger shock trial investigators, the use of balloon pump in Europe really plummeted after IABP shock. So I think that's part of the reason, I think, why they didn't. In fact, it's really interesting if you read the nuances of the protocol in danger shock, they actually, because it took them 10 years, they actually stopped doing multi-vessel PCI too, because of how much data were coming out during that trial. And unfortunately, initially, because of the Class 3 recommendation for balloon pump, Getinga was actually interested in doing another trial. But because of sort of commercial reasons and the spin-off, they've decided not to develop the evidence base for balloon pump any further, which is unfortunate.
Well, I think in Canada we still have to do it.
Yeah.
We have time for one quick question because we do need to move on.
So a quick question. So you spent some time early on, Sunil, and just a masterful presentation talking about focusing on type 1, not type 2 MI, but you seem to equate type 1 MI with plaque rupture, right? And we know that's probably not the case, right? Maybe 60, maybe 2/3 of patients are really plaque rupture, but at least 1/3 are other mechanisms. And that's important because, moving forward, as we sort of define phenotypes in the future and our imaging gets better, there may be an entire cohort that we would treat and address differently, right? So
I think that's right. Yeah, I think you're right. I mean, there are obviously, as we get smarter about these mechanisms, we're going to probably have to figure out how to tailor the treatment strategies. Again, unfortunately, the trials that have included these patients with ACS kind of use the same treatment strategy regardless of the mechanism. It was kind of antiplatelet therapy, antithrombin therapy, and then PCI. But moving forward, it's entirely possible that those strategies will change.
All right, great. Really fantastic discussion, so thank you so much again. Our last speaker will be Dr. David Kandzari, and he's going to be speaking about some future of renal denervation.
Thank you. Here's your clicker. I'll take it up. Now, do I need to stand up?
You have to stand. Walk the runway.
It seems impolite to have my back to you all, so I feel like I'm in Mercedes-Benz Fashion Week, perhaps. But we're really going to take a different direction here from guidelines and discussion of therapies for ACS and PCI to a therapy that now is becoming enveloped into guidelines and clinical practice. And it's a timely discussion for renal denervation therapy. Might you ever wonder how the term essential was labeled to what is the global leading cause of death and disability, that is hypertension? Well, as we look in EPIC medical records, electronic medical records, keeping discharge diagnoses, billing documents, hypertension is most often labeled as essential. And this dates to the mid-1800s with a German physiologist, Traube, who described hypertension as essential, believing that high blood pressure was necessary to perfuse the body through hypertrophied arteries, a consequence of uncontrolled hypertension, and to perfuse kidneys for excretory function of kidneys when indeed the kidneys were failing because of hypertension itself. And this postulate remained promoted without any contest for the next largely 80 years. And in fact, the founder of American medicine, William Osler, also promoted this concept of likening hypertension and its necessity to life as the Nile was to Egypt, of weeding out tributaries, perfusing our bodies and our organs. And what's interesting is that Osler also discussed the varied phenotypes of uncontrolled hypertension, with some individuals having very severe hypertension and yet demonstrating no consequences or end organ failure, and others, of course, experiencing sequela of stroke or kidney failure or heart failure or death itself. He also likened this unpredictability of the manifestations of hypertension, which we recognize so well as a condition that most often is asymptomatic until end organ failure ensues, as the variability of his Gillette razors, some being sharp out of the box, others being dull, or the variability of the quality of cars made on a Friday versus a Monday. But equally important, if not of greater relevance, and even still exists today, as he described the failure of contemporary therapies, which at least at that time were limited to nitrates and potassium iodide. Well, despite the expansion of a pharmaceutical therapeutic armamentarium of medications to treat hypertension over the next several decades, approximately 15 years ago, Alberto Nkechi, the editor of the journal Hypertension and a famed hypertension clinical investigator, stated that at that time, 2 decades, 46 trials, and more than 230,000 patients was probably too many to end up with the simple conclusion that what matters most is lowering blood pressure no matter what agents are administered. And today, we could perhaps expand that statement to state that not only what other agents are administered, but what renal denervation technology might be available. The opportunity for device-based therapies for hypertension, and specifically renal denervation, is realized through the recognition in the United States alone that 1 in 2 adults is affected by hypertension. And yet among individuals with hypertension in this country, more than 3/4 have blood pressure that does not meet societal or guideline recommended treatment goals. And there are multiple reasons for this, from physician inertia to patient non-adherence, but perhaps one of the best examples of the challenges of sustaining blood pressure control in individuals stems from the famed SPRINT trial, which revolutionized our guidelines endorsing more intensive blood pressure lowering. A study, recall, that demonstrated moving from a target systolic blood pressure of 140 in the office to 120 translated to a 27% relative reduction in mortality. And indeed, those individuals experienced a clinical benefit coincident with lowering of their blood pressure, but after the period of observation in this trial, through longer-term follow-up, those individuals who were assigned to the more intensive blood pressure lowering experienced an erosion of blood pressure control annualized year over year, such that they ultimately ended up with a higher blood pressure at the end, and they forfeit that clinical benefit. To level set to expectations with regard to the magnitude of blood pressure lowering with a single antihypertensive agent from meta-analysis of 51 large-scale randomized clinical trials totaling nearly 350,000 patients, the average reduction in office systolic blood pressure with a single antihypertensive agent is about 5 millimeters mercury. And even in the context of these trials, similar to the SPRINT experience, in the left-hand panel over longitudinal follow-up, there's a waning benefit, a waning reduction in blood pressure, likely due to patient non-adherence. Approximately a decade ago, we published the Simplicity HTN-3 study examining renal denervation therapy for very severe treatment-resistant hypertension. The average office blood pressure was 180 millimeters mercury. These patients were taking, on average, 5.1 antihypertensive medications. And the study demonstrated that with radiofrequency renal denervation, we could successfully reduce blood pressure from baseline. It was a very safe procedure, but the study did not meet its primary endpoint, not demonstrating a difference in the primary efficacy endpoint compared with the sham control group, because in part of a wholly unexpected reduction in the sham control group with their blood pressure at 6-month follow-up, a group in whom medication adherence and prescription of medications was assumed to be constant and without change. Victor Zhao, not specific to renal denervation, however, once stated that novel discoveries that challenge traditional thinking are often met with criticism, and it's important to have objectivity, belief, and perseverance. And indeed, it's to this latter endpoint, or this latter issue of perseverance, that the investigators and the sponsors of this program, who realized many of the instances of clinical benefit with renal denervation, pursued this therapy in its clinical endeavor with a change in how we conducted clinical trials, how we defined at endpoints, how we performed the procedure, and in whom we performed the procedure as well. But just as a brief validation of the Simplicity HTN-3 study over long-term follow-up, those individuals assigned to renal denervation have a sustained reduction in their blood pressure over 3 years of follow-up, and very importantly, without an escalation in their medication burden. And in comparison, just as with the SPRINT trial, those patients in the sham control group with medications alone experience an erosion of their blood pressure control and return to their normal high state of hypertension. To date, we have 2 FDA-approved technologies for renal denervation for uncontrolled hypertension, one with intravascular ultrasound, one with radiofrequency renal denervation. And amidst these 2 technologies, there are fairly consistent reductions in blood pressure that are not only statistically significant compared to the control in most instances, but clinically meaningful. And moreover, These studies represent 9 sham-controlled randomized clinical trials, which really sets a standard or a precedent unlike any other device therapy that has been studied with such rigor in the cardiovascular medicine space. Moreover, the successes of these 2 technologies have introduced new methods of renal denervation, in part with other methods of radiofrequency energy delivery, but also with perivascular drug delivery, with chemical denervation that also demonstrate promising results and safety. In fact, there are a number of new technologies being explored in the space of device-based therapies for hypertension, but specific to renal denervation alone, there are methods of chemical or perivascular alcohol drug delivery to achieve renal denervation, newer intravascular ultrasound and radiofrequency technologies, transureteral denervation, laparoscopic radiofrequency renal denervation in an ongoing first-in-human study now in the United States, and also exploring multi-organ denervation. The hepatic artery, for instance, has a rich abundance 3 times greater in the number of sympathetic innervation nerves surrounding the hepatic artery than the renal arteries, and combined hepatic and renal artery denervation, as we're performing in the Gemini pilot study now with radiofrequency energy delivery, has the potential promise to achieve perhaps greater reductions, more consistent reductions in blood pressure, or perhaps influence other metabolic parameters. But as this technology is being approved, and as we'll soon discuss, is at a timely juncture with regard to reimbursement in the United States, many clinicians ask themselves, does renal denervation therapy work all the time or just certain time points? Is it a durable therapy? Might our patients reduce their medications coincident with a reduction in their blood pressure? Does the benefit wane over time, or is it instead durable? And might my patient derive a clinical benefit aside from reducing the blood pressure number itself? And for payers and hospital administrators too, is renal denervation a cost-effective therapy? As we initially described several years ago now in the Spiral HTN OnMeds pilot study, across all clinical trials and with both modalities, renal denervation is associated with an always-on effect. That is, compared with baseline to follow-up and over a 24-hour period, the blood pressure reduction achieved with renal denervation is constant over a 24-hour period. This is certainly distinctive from the pharmacokinetic profile of medications, from the dosing regimen of medications. It is certainly important to those individuals whose blood pressure phenotype might convey a high risk for adverse events such as mortality and its association with nocturnal or early morning hypertension. And it's certainly distinctive from the limitations of patient adherence. This issue of an always-on effect may be especially relevant to those individuals whom we commonly encounter with hypertensive crisis or hypertensive emergency. In a recent analysis of nearly 60,000 patients presenting with hypertensive emergency in the United States, nearly a third have no prior history of undiagnosed hypertension, recognizing the asymptomatic condition of hypertension until an event such as an urgency occurs. 2/3 after presentation remained with uncontrolled hypertension at 6 months after presenting with a hypertensive urgency. And even in their presentation to an urgent care clinic or an emergency room, 41% were still prescribed and left in hand with a prescription for only 1 antihypertensive medication, or in some instances, none. We've recently demonstrated at the European Society of Hypertension meeting this summer that renal denervation therapy substantially reduces the likelihood for hypertensive urgency or recurrent episode as well by over 40%. And this may be a particular of relevant benefit for these patients with severe treatment-resistant hypertension. We've also demonstrated with radiofrequency and ultrasound denervation that coincident with a blood pressure reduction, at least for selected patients, they may be able to reduce their medication burden, represented by the number of medicines, the class of medicines, or the dose of medicines, all 3 of those features being highly predictive of non-adherence. Or it may be that fewer medications are required to achieve blood pressure recommended treatment goals. In part because of the pioneering and experience with radiofrequency energy denervation as the first technology used for renal denervation therapy, we have the luxury of the greatest long-term follow-up with this particular technology. And across these studies, both sponsored and investigator-initiated, through 3 years, 5 years, and now even through 10 years of follow-up, Following radiofrequency renal denervation therapy, there are sustained reductions in blood pressure, and notably across all of these trials, the blood pressure reductions are, if anything, amplified from those observed at 3 and 6 months. And moreover, in every one of these trials, it's without an escalation in the medication burden. As an example of such, in the Spiral HTN OnMed study, this always-on effect is still maintained at 3 years of follow-up. These are the figures at 3 years of follow-up from the Spiral OnMed's experience, demonstrating the change over 24 hours from baseline to follow-up for the renal denervation and the sham control groups, respectively. And yes, now there is a change in the sham control group, but this is because of a heightened escalation of medication dose, number, or class. But still, even in the renal denervation group, the magnitude of blood pressure lowering is greater at 3 years than that achieved with medications alone. So it highlights the complementarity of renal denervation combined with medications to achieve even greater reductions in blood pressure. Or viewed in another perspective, more than twofold the number of patients achieved a blood pressure of less than 140 at 3 years compared to those in the sham control group. The most recent example of this over longer-term follow-up stems from the Spiral HTN OnMed study at 2 years of follow-up, where again we demonstrate that compared to the sham control patients, there are greater, if not amplified, reductions in blood pressure over longer-term follow-up. But very important, these greater reductions in blood pressure are achieved over long-term with fewer medications compared with the sham control group. This may be due to changes in the sympathetic condition or the signature within the body. It may be due to differences in vascular remodeling that occur later over time, but a consistent finding are sustained, if not greater, reductions in blood pressure beyond the initial period of 3 or 6 months, which are traditional endpoints in these trials. And finally, in a meta-analysis of nearly 4,500 patients with 4.5 years of follow-up, with renal denervation therapy, the average reduction in office blood pressure approaches 23 millimeters mercury. The average ambulatory, 24-hour ambulatory reduction is 14 millimeters mercury, which is quite significant. And again, consistently across all of these trials without an increase in medications through latest available follow-up. Very importantly, beyond the more restrictive criteria of these sham-controlled randomized clinical trials, in real-world clinical practice, and as evidenced here in the Global Simplicity Registry totaling more than 3,000 patients and with now more than 3 years of follow-up, there are sustained reductions in blood pressure following renal denervation therapy across individuals poised at heightened cardiovascular risk. Those with, who are elderly with isolated systolic hypertension, those with prior stroke or myocardial infarction, patients with diabetes, and patients with chronic kidney disease, among others. Renal denervation therapy is also exceptionally safe, not only in the peri-procedural period itself, with, at least in the context of clinical trials, no unanticipated adverse device events, but over longer-term follow-up, as evidenced in meta-analysis of over 52 trials, that there is no annualized decline in the eGFR compared with controlled patients. And if but anything, there is data that would support a mitigation of the annualized decrease in GFR, which would be expected in a patient population with uncontrolled hypertension. Moreover, in over 10,000 patient years of follow-up, put simply, the occurrence of renal artery stenosis with renal denervation therapy is case reportable. It's at an incidence that is less than that which would be anticipated of a similar patient population with atherosclerotic disease risk. Just as there are no direct correlation trials of improving outcome with the drugs that you and I so routinely prescribe in our clinics for the treatment of hypertension, recall that all of those are based instead on meta-analyses of many different clinical trials. To date, we don't have any direct one-to-one correlated outcomes clinical trial with renal denervation therapy. But we do have surrogate data looking at time in therapeutic range. That is, after renal denervation therapy, the greater time spent in therapeutic range, similar to what we akin to glycemic control in diabetes, is associated with linearly a reduced risk of death, of stroke, and of myocardial infarction. Given the adverse sequela of hypertension and its recognition by third-party payers and hospital administrators, among others, that a hypertensive patient represents a high-cost center individual, and given that any modest reduction in blood pressure translates to an improved outcome, with a 10 millimeter reduction in systolic blood pressure translating to a 10 to 15% reduction in mortality and a 25 to 30% reduction in stroke and heart failure and myocardial infarction. Renal denervation therapy is expectedly poised as a high-value, cost-effective therapy. It is associated with an incremental cost-effectiveness ratio that is highly favorable compared with contemporary standards across a range of levels of hypertension, across a range of patients' ages, and even in the most conservative estimates, even across a range of reductions in blood pressure that can be achieved with renal denervation therapy. Finally, as we'll soon discuss in recent consensus documents and in guidelines, there's an emphasis on shared decision-making and patient preference for thinking about treatment for uncontrolled hypertension. And this is relevant given that perhaps as a surrogate or marker of patient preference is the issue of non-adherence, which is epidemic worldwide in the field of hypertension. Insurers recognize, for instance, that at least a third of their constituents with hypertension are non-adherent to their medical regimens. And even in clinical trials, in part perhaps recruiting the best of the best patients with hypertension who are the most motivated to do something about their uncontrolled hypertension, even with their awareness of our purpose of testing their blood and urine for detection of their prescribed antihypertensive medications, still at any one time point, 40 to 60% of the patients have partial or complete non-adherence to their prescribed medical regimen, and again, even with the knowledge of the purpose of such testing. In the most rigorous of perhaps most rigorous of patient preference studies termed a discrete choice experiment, we've offered for 400 US patients who are not part of renal denervation trials but have uncontrolled hypertension different attributes of two therapies, renal denervation or drug therapy. And depending on the attributes or the benefits and the risks associated with each therapy, anywhere from 20 to 40% of patients would prefer a therapy such as renal denervation rather than escalate their medications. And the two most important attributes for a therapy, whether it's a drug or a device for patients with uncontrolled hypertension in the survey, are number one, the magnitude of blood pressure lowering, which seems reasonable, but also its longevity or its durability. And they favor those two features over safety or side effects or any other issues associated with the therapy. To date, there are now more than 20 societal documents and or expert consensus documents and now guidelines that are endorsing renal denervation therapy and informing clinical practice on how this therapy may be enveloped into more traditional standards of care. These stem from, most recently, the Society of Coronary Angiography and Interventions and the National Kidney Foundation, the European Society of Heart Failure, the European, or hypertension rather, the European Society of Cardiology, the American Heart Association, most recently, and forthcoming, the ACC and AHA. Altogether, there are some common recommendations about renal denervation, expectedly prioritizing those with, of course, uncontrolled hypertension and or treatment-resistant hypertension, but also those who may be intolerant or non-adherent to medications, those at increased cardiovascular risk, and again, referencing patient preference as an important part of the shared decision-making process. Lifestyle interventions and medications remain the foundational elements for the treatment of uncontrolled hypertension. However, the abysmal levels of hypertension control, not only in this country and worldwide, the recognition of the sequela of hypertension, still to date the leading cause of death and disability, invite the opportunity for safe device-based therapies like renal denervation to be included in the armamentarium for the treatment of hypertension. Renal denervation, therefore, is appropriately now being incorporated into guidelines for the treatment of hypertension, as it has resulted in not just statistically significant, but clinically meaningful reductions in daytime and nighttime blood pressure, in office and ambulatory blood pressure, in the presence and absence of medications, and very importantly, with exemplary safety, not only at short-term, but over long-term follow-up. With the advent of therapies for hypertension, however, we need to equally insist on stepping up our game in the medical community, to step up our attention to what remains the leading global cause of death and disability. And the opportunity to do so for you exists today. Center for Medicare and Medicaid have issued their national coverage decision for renal denervation therapy. This is presently, as of July 7th, it is presently open at cms.gov, and we invite you to write in your commentary, to review their coverage decisions, and provide open comment during this period. We expect later in the fall for this to be finalized with regard to CMS coverage and for third-party payers to follow suit. And so this reimbursement issue has been, for most programs, still a stumbling block for us to move forward with this particular therapy, and the time is now. So thank you again.
Thank you so much. I really enjoyed the talk. Unfortunately, I think we're going to hold any questions for now. I want to thank everybody for being here for this amazing session. Thanks to our panelists and our speakers.